Cystic fibrosis is a genetic disease that affects the exocrine glands, such as sweat and mucus glands. It is characterised by the production of abnormal mucus, which is overly thick and sticky, and can affect functional organs such as the lungs, intestines, and pancreas. Now the etiology. Cystic fibrosis is caused by mutations in the cystic fibrosis transmembrane regulator, or CTFR gene, on chromosome 7. The resulting abnormal CTFR protein causes disruption of cellular ion channels that regulate epithelial liquid volume through chloride secretion and sodium absorption inhibition. Cystic fibrosis is an autosomal recessive condition, meaning that it occurs equally in both genders and requires 2 mutated CTFR genes, one from each carrier parent. Cystic fibrosis carriers are those who inherit one faulty gene and one normal gene, and usually have no symptoms of cystic fibrosis. Over 1,600 mutations of the CTFR gene have been discovered, and each mutation has varying effects and severity. However, the most common mutation is deletion of phenylalanine at codon 508 and occurs in 70% of those with cystic fibrosis. I will now discuss the pathophysiology. As discussed previously, the pathophysiology of cystic fibrosis stems from a defective CTFR protein, creating abnormal transport of sodium and chloride ions and water across epithelial cells of respiratory, genital, and digestive tracts. The specific details of cystic fibrosis pathophysiology is not exactly known, but a popular explanation is the low volume hypothesis. This proposes that due to altered channels, a reduced volume of surface liquid in the airways results and acts as an obstacle to mucociliary clearance. Normal mucociliary clearance works in 2 ways. Respiratory cilia beat to propel mucus and any trapped substances to the pharynx to be swallowed and be killed by the highly acidic hydrochloric acid in the stomach. Secondly, the mucus of the airways is an important substance. A periciliary, meaning next to the cilia, volume, separates the mucus and ciliary layers to promote cilia movement and prevent glycoproteins in the mucus from sticking to the epithelial membrane. Mucus usually contains 97% water and 3% solids, such as water-binding mucin, immunoglobulins, etc. This consistency allows mucus to be easily cleared away during ciliary beating, and the large amount of water allows buffering of surface liquid or periciliary volume in times of airway hydration variation. However, in those with cystic fibrosis, the water content of mucus is greatly diminished due to the mutated CTFR, which cannot transport chloride ions. Sodium ions travel with chloride ions as NaCl, and if sodium ions do not pass through, then neither does water, resulting in a dehydrated mucus that is much thicker and can clog airways, as well as a shrunken periciliary layer, thus inhibiting mucociliary clearance. The stagnant mucus containing trapped antigens from inhalation results in an intense inflammatory response and infection. In fact, an individual with cystic fibrosis will have up to 10 times the inflammation of a normal person. Persistent inability to clear out pathogenic mucus can result in chronic inflammation and airway obstruction. This results in bronchiectasis due to weakening of bronchi walls and dilation of bronchi in an attempt to clear out the thick mucus. This aggressive cycle of obstruction, inflammation, and relentless infection causes further decline until respiratory failure and death. There are many clinical signs and symptoms, but today we'll just look at 5. The first is a big appetite but poor weight gain due to clogged mucus secretions in the digestive tract, which blocks food absorption, causing malnutrition and vitamin deficiencies. The second is stunted growth, again caused by malnutrition. The third is bulky, smelly, greasy bowel movements caused by steatorrhea, which is fat in the feces due to malabsorption. A fourth symptom is frequent coughing and wheezing due to a reliance on physical movement to shift mucus towards the pharynx as movement of cilia is limited. And the fifth symptom is salty tasting skin, which occurs because salt and water from sweat is usually reabsorbed through sweat ducts. However, the mutated CTFR doesn't allow re-entry of chloride ions, and thus salt remains on the skin. And lastly, epidemiology. Cystic fibrosis is a fairly common genetic disease in Australia, with it occurring in 1 in 3,700 births. Additionally, about 1 in 25 Australians are genetic carriers of cystic fibrosis. For Australian Aboriginal and Torres Strait Islanders, cystic fibrosis is rare, and there is currently not enough data to demonstrate its epidemiology in the Indigenous population. Figure 1 demonstrates a fairly even spread of cystic fibrosis in both males and females, with most individuals aged 10 to 14 years old. As age increases, the bars decrease, especially after the 30 to 34-year-old bracket, because this age is most likely when respiratory failure and death occur for those with cystic fibrosis. Figure 2 demonstrates the prevalence of cystic fibrosis throughout the different states of Australia. There is an almost even occurrence of cystic fibrosis in children and adults, with Queensland having the most total people with cystic fibrosis and Northern Territory having the least.